Hi, my name is Dr. Rob Emiat. I am a board-certified foot and ankle surgeon. Today, I'm going to introduce you to the Relja Innovations MIS Precision Chevron Bunion System. The MIS Precision Chevron Bunion System allows surgeons to perform a chevron bunion surgery through a small 1 centimeter incision. It is familiar to the way surgeons perform chevron bunionectomies today. It uses a traditional saw blade. The saw blade is utilized through the osteotomy slot, which you can see in lime green here. The osteotomy slot is radio opaque, so it's easily visible on the radiographs, which you can see down below. This system has a precision aiming guide for placement of a cannulated screw. The system is quick, it's accurate, it's repeatable. It comes in a sterile packed kit with a precision osteotomy guide, all the instrumentation needed, and two different screw sizes for different sized anatomy. This is the results of the Relja Innovation System with a traditional chevron osteotomy and a 3.5 headless compression cannulated screw. As you can see here, the 3.5 headless compression cannulated screw goes directly across the apex of the osteotomy. On the AP image on the left, you can see a traditional chevron procedure performed that is moved over a moderate amount. This system is a targeted sterile procedure kit. It has a single skew. It's a 1 centimeter incision. The indications for use are the mild to moderate bunion deformity. It's for those patients who have limited hypermobility of the first ray, those patients with limited frontal plane rotation, those patients that you would traditionally choose to perform an Austin or chevron bunionectomy would be ideal candidates for the Relja system. Today, still 50 to 70% of bunions performed are still the chevron procedure. Now I would like to take you through the technique guide. At the surgeon's discretion, you can perform minimally invasive lateral release with releasing the lateral first MPJ capsule, as well as the conjoined tendon of the adductor hallucis. Next, we want to find the midline of our first metatarsal. So at the area of the incision, we take one of the 0.045 inch K-wires that come in our sterile packed kit. We place one of those with our hand directly above the first metatarsal into the soft tissues above the first metatarsal, and the second one just below the first metatarsal so that they stand parallel on their own. Once in the correct position, we place a small dot with a marking pen to indicate midline. It is also indicated to do this in the mid shaft of the first metatarsal. Next, utilizing fluoroscopy, we take a lateral x-ray. As you can see here, we take those same K-wires that we just used, we lay them on the medial aspect of the first metatarsal over the skin marking dots that we just made, and verify that the midline is achieved. Next, at this time, we mark that midline along that K-wire all the way from the base of the first metatarsal just past the first MPJ. Next, we will place a vertical line perpendicular to the previous horizontal line. With this, we want to place that vertical line, and we utilize a K-wire to get the exact position we desire for the vertical line. And we utilize this K-wire to show us exactly where we want that mark. We really want to mark that vertical line in this position where it's just proximal to where that medial eminence falls off. You can see the same over on this side. We really don't want it any more proximal or distal than what you see here on the right. Next, at this time, we take the osteotomy guide and we line this up with our skin markings. There is a small insert on the end, an opening in the middle, and a notch on the proximal portion. These are simply lined up with our horizontal line that we made on the skin. Next, you can see right up at the top here, there is a vertical notch, which you also will line up with the vertical skin marked line. Next at this time, we take the white targeting guide and we place this on the clear precision osteotomy guide. This helps target the osteotomy guide into the correct position in all three planes. We do this by placing a mark on the fourth metatarsal phalangeal joint. And then we place the osteotomy guide in line with our skin markings and aim this towards that fourth metatarsal phalangeal joint mark. I will demonstrate this to you. So we take our osteotomy guide, we place the white targeting guide on the prominent. Then on the foot, we have this lined up on the medial aspect with our skin marking lines, and we really want this aimed directly across the foot, similar to what we utilize a access guide K-wire for a traditional Austin osteotomy. We aim this towards the fourth metatarsal. We don't want this sitting up in the air like this. We really don't want this way down against the skin. And again, we want to aim towards that fourth metatarsal phalangeal joint. We don't want it aimed back here like this, and we don't want it aimed too distal. Once we have that in the correct position, we insert our first K-wire. Once we insert our first K-wire, holding the precision osteotomy guide in the correct position proximally, we take a lateral X-ray to confirm that the osteotomy is in the correct position. To get this proper lateral, we really want to see as minimal of our first K-wire that has been inserted into the first metatarsal. You really want to see that K-wire as almost a BB on this X-ray to get that proper lateral position. Here you can see our chevron osteotomy guide slot is midline of the first metatarsal, and it is in the neck of the first metatarsal, which is the desired position. Here's another example of, again, getting a good lateral X-ray where we can see just a small amount of our K-wire. But here you can see our osteotomy is midline of the first metatarsal, but this is just a little more proximal than desired. With the Relja Innovations Precision Osteotomy Guide, if you notice here, there is a center hole in the osteotomy guide, and there are surrounding holes around this. So we know that with the last X-ray you saw, we need to move the precision osteotomy guide, which creates our osteotomy, more distal. So instead of having to take the K-wire out and line everything up and put the K-wire back in a position that's a little distal, what we can do is slide the precision osteotomy guide off of the first K-wire that we inserted and then place it in this proximal hole, which will then move our precision osteotomy guide distally 1.8 millimeters and into that more correct desired position. With this, you can also move the osteotomy guide proximal, superior, and inferior, utilizing the different holes surrounding the center hole. Next, at this time, we rotate our precision osteotomy guide dorsally. And if you notice, on the precision osteotomy guide, there is a curvature within the guide. This will allow you to create your vertical incision right along that curvature. And the little notch here to the little notch here is exactly 1 centimeter. So next we make our vertical incision, we perform our dissection, we create a small pocket on the top of the metatarsal and a small pocket on the bottom of the metatarsal. For your first, second, fifth case, however many is desired, you can certainly start with a 1 to 2 centimeter horizontal incision, so you can actually visualize and have some comfort in visualizing that the osteotomy is in the desired correct position, both radiographically and with your eyes. Next, at this time, we, after we have performed our dissection and created a small pocket on the top and the bottom of the first metatarsal, we insert our retractors. And as you can see, these small retractors come with the kit. There's one that is shorter and that there's one that is longer. The longer one goes just on top of the first metatarsal, as you can see here. And what that does is it retracts the soft tissues and it goes right between the first metatarsal and the extensor hallucis longus tendon. So while you are making your osteotomy, this retractor is protecting your tendon. The same goes for the plantar aspect. Once these are in place, you can certainly use a freer at this time to feel the top of the metatarsal and the bottom of the metatarsal to verify midline of the first metatarsal and that our K-wire number 1 is in the correct position. Next, you rotate the precision osteotomy guide planter and line it up with the notches as we discussed before. Next, at this time, we take our second and third K-wires and we insert them into the blue alignment screws. We place them in by hand and then grab our K-wire driver and insert them into the first metatarsal, making sure that they are bicortical. Next, at this time, we take our screw guide, insert that into our alignment slot on the top, and insert that up to the skin overlying the middle of the first metatarsal. Once we're in the skin right over the first metatarsal, we make a small incision and we dissect down to the bone, retracting the extensor hallucis longus tendon. Starting with midline of the first metatarsal, we then insert our guide wire and we really want to aim to the lateral aspect of the first metatarsal so that once we move the first metatarsal over into the corrected position, then the K-wire will actually, the guide wire will actually be in the middle of the first metatarsal. Again, here you can see that the entry point is proximal to our osteotomy, so the screw will not get too close to the osteotomy, and you can see that the guide wire is going directly across the apex of our osteotomy. At this point in time, we insert that guide wire once we have verified it's in the correct position, and we insert that to stop just short of our first metatarsal phalangeal joint. We take a measurement. If we measure a 32 millimeters or greater, we insert a 27 millimeter screw. If we measure less than 32 millimeters, we insert a 24 millimeter screw. Once we've verified which screw we will use, we back this up to the number 10 slot on our screw guide. And you can see here that our number 10 slot keeps the guide wire just behind the osteotomy. It will be in the bone approximately 1 centimeter and ready to go for insertion after we make our osteotomy and move our first metatarsal over in the correct position. Next, at this time, we retract the skin planter when we are making our plantar osteotomy. And so we start at the apex and go directly across. We bury the blade. This is a traditional sagittal saw blade that we use in everyday bunion surgery. The only difference is instead of it being a 9x25, it's a 9x31, so it's slightly longer as we have a little more distance to go through with the precision osteotomy guide. We perform our osteotomy from the apex, and then secondly, we get the plantar cortex. Next, when we perform our dorsal osteotomy, we retract dorsally, and we start at the apex and go all the way across, again, burying the blade. Then we aim slightly dorsal to get the dorsal cortex. After our osteotomy is performed, before we take our precision guide off, we verify that we are all the way through with the saw turned off, so we can feel that we are all the way through the bone. After we have completed the osteotomy, we take our first, our second, and our third K-wires out, and then we slide the precision osteotomy guide over the guide wire at that time. Here you can see our retractors are still in place, our guide wire is still in place in the correct position, and we have a very nice chevron osteotomy. Next at this time, we reduce the deformity, and we do that by distracting the great toe and pull the great toe distal and lateral. While we are doing that, we push on the medial aspect, we push on the lateral aspect of the first metatarsal in more of a medial direction. By distracting the great toe, that has helped this move over properly without having to use a freer or other instrument to push it over. Using a freer or other instruments like that, we have noticed in the cadaver labs that this will damage the osteotomy and it won't sit properly once moved over. Once you get this in the correct position, which you can see here, this is moved over, so it is touching the second metatarsal. You confirm that position under fluoroscopy on both AP and a lateral. Here you can see our osteotomy is performed. There is no gapping of the osteotomy, and our guide pin is in the correct position, just proximal to the osteotomy, ready to be inserted. Next, with that first metatarsal held in the correct position, we place the screw guide back on the guide wire before we insert it. Next, we insert the screw guide to the previous measured length that we measured earlier in the procedure. That will have that guide wire go past the cortex plantarly into the first MPJ, just a couple millimeters. And that is actually good because it will help hold this in the correct position while we are inserting our screw. Next, we take one of our one of our K-wires that we previously used, and we insert that from proximal medial to distal lateral as a temporary fixation before we place the screw. Next, at this time, we use our drill and countersink. As you can see here, we made our own drill and countersink. This has a very short drill bit. It has the countersink built in, and it has a ledge here that is a positive stop. So when we make our small incision on the top of the foot over the first metatarsal, it's hard to visualize if we've countersunk enough. This will allow you to countersink the appropriate amount and hit a positive stop, and so you know when you're done. Next, at this point in time, we retract the skin and the extensor hallucis longus. We insert our 3.5 headless compression screw. You can see the blue screw we're inserting on this photo right here, which is the 27 millimeter length. We also have a green screw that is a 24 millimeter length. Once the screw is inserted, we confirm that it is properly seated and it is not sitting proud, and we confirm x-rays with both an AP and a lateral. Here again, you can see we have a nice chevron osteotomy with a good shift, and our 3.5 headless compression screw is going directly across the apex of the osteotomy. Here's another example of a chevron osteotomy with a good correction of the deformity with our screw going directly across the apex of the osteotomy. This here is an example where this osteotomy could have been made slightly distal, more in the distal shaft and neck area. Here's another chevron osteotomy performed with our screw going directly across. Again, we have a nice shift of the osteotomy with our screw placed across the apex of the osteotomy. Next, at this point in time, we resect the medial bone shelf, we remove the guide wire, when we remove our temporary fixation, We make sure that there is no prominences, and we flush and we close our incision. Here is our sterile packed kit. Everything you need comes within the kit, single-use sterile pack kit. Thank you very much for the opportunity to show you the Relja Innovations MIS Chevron bunion system.